So today I'm joined by our reproductive endocrinology and infertility specialist, Dr. Lucky Sekhon from RMA Fertility in New York. And we're going to do another one of these sessions that I've done before with you, a fertility Q&A. We solicited questions for the past week or so, and we got some really good ones this time. So I'm super excited for this discussion. How are you today?
I'm doing great. Thank you so much. I love doing these with you. And I agree.
Yeah.
I was scrolling through your comment section and so many good questions. So little time.
Okay. Yeah. Okay. Well, the first question is this, pretty straightforward. Do most women or individuals get pregnant naturally after age 35?
Well, before I answer the question, I need to step up on my soapbox to say I hate the word natural.
Yeah.
I get what people mean when they say that. But I feel like it stigmatizes women who do need the help of assisted reproductive technology to conceive. So I think what you mean is to conceive without treatment. And I would say,
or
yes.
I like to say spontaneously.
Yes, spontaneously or without treatment. I think either one of those work. But I would say you shouldn't assume that you're turning 35, so that means you're definitely going to need treatment and need help to conceive. But I will say that, 20 to 25% of ovulate in a pregnancy in one's early 20s. And that figure drops to about 5% or less over the age of 40. The major player in all of that is egg quality and how it changes over age. And there's no direct way to test your egg quality. So there's no accurate figures that I can tell you in an individualized way that will predict your chance of conception on a given month, according to your age. But we know that it changes, and it changes more rapidly. So the odds of needing treatment or help to get there increase, particularly over the age of 35 and definitely over the age of 40.
And we talked about this before, but I'll just mention it. It's important if you're hitting that age 35 mark, if you're not having regular cycles and you're hitting age 35, then you need to be evaluated. You got to first start, your best chances are going to start with regular menstrual cycles, correct?
Correct. Yes. I think if there's any sort of red flag, whether it be irregular cycles where you feel at a loss in terms of being able to track when you should be trying, or if you have a known strong family history of certain gynecologic disorders or premature menopause, if anything like that is a red flag in your history or your cycle pattern, it's a reason to get an evaluation sooner rather than later.
Agreed. And I always recommend too, even though you may not be actively trying to conceive, tracking your periods is important because sometimes people just don't realize that there might be a little bit of offs here and there, and they may not actually have regular menstrual cycles because they're not thinking about trying to conceive at that point. So it's always a good idea to just go ahead and track it anyway, especially once you start hitting that mid-30s mark. Do you think that would be a good idea?
Yeah, I mean, I always say, and maybe this is a little dramatic, that the menstrual cycle is like another vital sign, right? And understanding how regular one's menstrual cycle is, or whether there's a change in the pattern of bleeding, like having all of a sudden much heavier or much more painful periods, or even gradually over time, could be a sign of an underlying gynecologic disorder like endometriosis or fibroids. And these are things that left unchecked could impact your fertility. So I think that it's important for everyone to be paying attention.
Good. All right, let's move on to the next question. The next question was, would you suggest an HSG test for those 35 plus to see if their tubes have any blockage? First, briefly describe what an HSG is and whether or not it's a good thing to do for anyone over age 35 just to see if their tubes are blocked.
Yeah, so an HSG is basically an X-ray of the pelvis that's done after a radiologist or an REI, either one of those individuals can be doing this test, instills a type of dye that enters the uterine cavity. It's contrast. It enters the uterine cavity and then spills into the fallopian tubes. And if the tubes are unblocked or unscarred, it should spill from either end. And the way this is visualized is by taking that X-ray of the pelvis. So they push it in, they wait for it to enter the reproductive tract, they take the pictures, and then we interpret the images. And not only will it tell you if your tubes are open or or blocked on either side, but it can also give you a nice silhouette of the uterine cavity, which should look like a triangle. And so it can diagnose things like a septum or different types of anomalies that can happen with the uterus when you were a fetus in your mother's womb, or structural issues like scar tissue, fibroids, or polyps. So it's like a 2-for-1 test. And I don't really know why the question was posed about being over the age of 35, because I think this is a good test for anyone to do if they've been trying to conceive, and they're not sure why it's not happening. This is one way to evaluate the reproductive tract, and it's a mainstay of the initial infertility workup. I think maybe they said over the age of 35 because they're implying that they don't want to waste time. So sometimes doctors will say, wait a whole year to do this. If you're young, there's no need to rush to do testing, which I agree with in some respects, but I don't think it's ever wrong to be proactive about testing, especially if you have known risk factors. If you know that you have endometriosis, that's a risk factor for having scarred blocked tubes. If you've had prior STIs like chlamydia or gonorrhea or pelvic inflammatory disease, that's a risk factor for tubal disease. So if you've had an ectopic, that's a risk factor for tubal disease or blockage. So why not just get tested earlier? Because if the tubes are blocked, you're going to probably need IVF to bypass them, and therefore it's better to find that out earlier rather than later.
Right, so it's not really applicable to the age. It's more applicable to how long you've been trying. If you have any of the risk factors that Dr. Sekhon just mentioned, then the HSG might be a good thing to do just to evaluate to see what the tubes look like.
Correct.
Okay. Let's move on to the next question. Is there a reason an AMH would be 0.003 one time and 1.3 when we rerun? I know it's probably not a question that applies to very many people. So we get, I get asked about AMH all the time. So just talk about AMH, and you did a great explanation on one of our lives before, but just talk about it and how, you mentioned before how it can vary from time to time and not always be the same. And then what it means at that one point in time, if that makes sense.
Yes. So AMH is a quantitative marker that tells us of your ovarian reserve, how many eggs you have. And it is a hormone that's produced by all of the little cells that line each follicle. Is a fluid-filled space that has one egg floating inside each one. And there's a certain number of antral or baseline follicles that you can count as a way to understand how many eggs you have overall, and more importantly, how many would be available if you ever needed treatment like IVF or egg freezing. So another way to assess that is also by measuring this anti-Müllerian hormone, or AMH, level in the blood work. And it can be measured whether you're on the pill, off the pill. So that's an advantage over other prior measures that like FSH, which is still used, but it's not accurate if you're on the pill and testing it. And it doesn't have to be measured at a particular point in your menstrual cycle. It can be checked throughout. It should stay pretty stable. The higher the number, that means you have more follicles and more eggs, right? So the better it is in terms of, worrying about how many eggs you might have available for treatment. And I make that distinction because every month we're all ovulating one egg. So your AMH does not tell me about your chance of conceiving and whether it's going to be easy or challenging, because it doesn't tell me anything about the quality of the egg that's being ovulated. It really only matters if you're going through treatment, or you may need to go through treatment one day in the future, or if you're thinking about doing something like egg freezing. And it's a lab test. So I don't want to say take it with a grain of salt, but would you make major life decisions just based on one lab test? So I always think that it's important to realize that assay of how the lab is run and tested in the laboratory can have other external factors affecting it. So that could explain why this individual had an undetectable or very low AMH, which was probably very concerning, and then all of a sudden it was normal. Also, there's studies that corroborate this, and I will tell you anecdotally, my experience is sometimes being on really long-term birth control can falsely suppress your AMH level. And if you go off of it and retest it in 1 to 2 months afterwards, there might be this rebound. Maybe this is a little bit of an extreme example, but that does happen.
Yeah. So, again, I think people, and we'll get into this with the next question actually, or one of the next questions. They put a lot of weight into AMH, and because there's a lot about it on social media, and what is your AMH, know your AMH for your future fertility and all that, but you have to take it the big picture. And what it's really used for, like Dr. Sekhon said, is it for someone that's anticipating freezing their eggs, to get a kind of a guesstimate, if you will, of how your ovaries might respond to the drugs you need for either IVF or to freeze your eggs. But it can't tell you much more than that if you're just wanting to get it just to get it. Does that sound about right?
Yes, exactly. It's very limited. And another major deficit is that I can't tell you based on what your AMH is today, how fast you're losing your eggs or when it's going to change. So I have patients who are interested in egg freezing, but they're like, you know what, I really like to hold off because maybe I'll meet someone, maybe I won't need to do this. At what point do I need to come back? Like when is there going to be a significant drop? And I can't tell them that.
Yeah. Yeah.
And so it's really what we can test for.
So let's segue into these at-home fertility tests because I see a lot about them. They're
Sure.
everywhere. They're advertised by celebrities. And I know there's more than one company that offers these at-home fertility tests, but just in general, what do most of these at-home fertility tests evaluate?
So most often they're checking the AMH because that's the sexy, newer hormone in my field. And it can really tell you about your egg quantity, which to the untrained person who didn't hear what we were just talking about it not being able to tell us about your natural fertility or egg quality, it sounds like a great test that's going to give you so many valuable insights. And, you know, I think that it's often marketed incorrectly. It'll also often involve the pituitary hormones like your FSH and LH levels. Maybe it'll test your estrogen and progesterone levels. Some of them have thrown in thyroid stimulating hormone, which we care about preconception.
Yeah.
And we want to make sure that your thyroid hormone is in balance. And then maybe even prolactin levels, which is another pituitary hormone that if it's elevated, it can cause irregularity in the cycles. So these are all tests that we may or may not run at an initial fertility consult because we don't just send a battery of tests off on everyone. There's no one size fits all panel. But I think what's really critically missing in this piece is the proper evaluation and interpretation of the test results and the proper counseling that should go along with it.
And you don't, and I hear, and I see it when, especially these celebrities, I did the XYZ at home fertility test and my future's looking good. That's not fair. That's not fair to say that. And I think it's a little misleading. Actually, it's a lot misleading because it's an at-home test. It's not for everyone to take. And it's not necessarily going to tell you a whole lot. It's just about that moment in time. It's not going to tell you what might happen a year from now or 6 months from now. So, you know, you don't have to agree with me, but I feel like it's just another marketing ploy.
No, I totally agree with you.
I do. Yeah.
I don't think everyone needs to go to their fertility doctor. And I'm not saying as a fertility specialist, everyone should make a consult with me. And that's why, you know, I'm threatened and I don't want you to just bypass me and do this home fertility testing because that's often the story that's spun around anyone that's critical of this. That's not at all what I'm saying. I work with and communicate with a lot of referring OBGYNs that are within my network of professionals, and I'll lend them my expertise. If they're having difficulty interpreting the results, they'll send the patient my way, but they often can be the ones to do the initial testing. And any doctor that's sending a test off on you should only be doing so if they're capable and willing to counsel you about the results.
Yeah, if it's indicated and if they know, you know, they know how to interpret the results. If they don't, they know who to ask to interpret the results.
Exactly.
You know, just beware of these at-home fertility tests. That's my take on it. And I'm not a fertility specialist. I just know that I see on social media and I kind of cringe every time I see one of these social media posts about it because I don't think it's quite fair and it's misleading and it's not going to give you a lot of, you know, what's the right word? Make you feel necessarily better just because of what your numbers are. There's a lot more to consider.
There's a lot of predatory behavior in the space of women's health. And you and I are on different ends of the spectrum, but we see it all.
Yeah, that's a great way to sum it up. It's very predatory. Okay, so let's go back up to this. Let's see. Okay, this is a good question. What do you know, Doc, about shared egg donation versus dedicated donor? I did donor egg pregnancy and I did a dedicated donor egg cycle. So explain the difference between shared egg donation process versus dedicated donor.
Yes. So anytime I have a patient that's interested in using an egg donor, an anonymous egg donor, they have the option of using previously frozen eggs. And that's usually done through an agency. and that will be a limited number of eggs, right? Or they can have a donor that's recruited through an agency to cycle just for them. And that is the more costly option because you're paying for that donor stimulation and everything associated with their treatment. Or you could split whatever eggs are yielded from that cycle with another recipient, individual or couple. And so that's known as a shared donor. I think it comes down to what your overall family building goals are. I think for anyone who wants to have maybe a very large family, 2 or more children, and it's important for them to be linked by the same donor, you may want to consider steering away from the frozen donor egg bank situation, because then you're going to be starting with a limited number, like 6 to 8 eggs. And that's usually good for, you know, maybe 1 to 2 live births, but definitely 1. If you're going with the other option where there's a dedicated donor cycling for you or yourself and another recipient, you're going to get a lot more eggs to start with. And that's basically what it comes down to. I think it's more economical for a lot of patients because they're splitting the costs down the middle.
With the dedicated donor. So yeah, with the dedicated donor, I went through the whole process, picked out the donor, and whatever eggs were retrieved were for my family. Whereas I know that, say, someone else had also picked that same donor, you could also do a shared, and you just split the eggs down the middle. Is that pretty much how it goes when you do the shared donor?
Exactly.
Yeah.
Exactly.
Okay. So you know what's the right option for you is going to depend on, like Dr. Sekhon said, what your family building goals are, what your budget is. And you know, I guess those are 2 main things. Once you've already decided to use egg donor, there's actually 3 possibilities of how to use them, as Dr. Sekhon just mentioned. And so basically family planning goals plus what your financial limitations may or may not be will kind of factor into which route you would go. Does that pretty much sum it up?
Yep. And then another consideration, which might be beyond the details required for our discussion, but something to think about is if you wanted to do genetic testing on the embryos, some people would rather that you use fresh eggs, meaning they haven't been previously frozen and you have an abundance of them, just because embryos, in order to undergo genetic testing, have to meet a certain requirement. And so there might be like a lower yield at the end of it. Also, it pays to start with a higher number of eggs, if that makes sense.
Gotcha. Yeah, that's a good point as well. Okay. Talk about AVA bracelets. This is another good question. And natural fertility monitors.
So this is in the category of, you know, biohacking, like using a Fitbit. It's that type of a thing. It's a bracelet that you wear constantly. So this could be a good option for people that are forgetful and aren't going to remember to take their temperature in the morning, or aren't going to remember to pee on a stick several times throughout the day. They're worried about missing their peak. So those are kind of the major pros. Cons that I've heard just from speaking to my patients and also just checking out their reviews online and some of the data at hand is that it's not 100% accurate, right? And it's not going to be something that you can use necessarily if you have PCOS. So it's not a huge advantage over ovulation predictor kits, which similarly can also be inaccurate in women with PCOS because they tend to have high baseline LH levels. And if that's the thing that you're waiting to find in your urine when you're peeing on those sticks, you know, you might get a lot of false positives. So it hasn't been validated for use in women with cycles longer than 35 days, which that applies to a lot of women with PCOS. But I think if you're one of those people that more information helps you and makes you feel better and you like to collect that data, there's certainly nothing harmful about it, but definitely get a sanity check and also just do the old-fashioned tracking with a calendar to see and make sure that the dates are lining up. It's very high tech because it's not just measuring changes in body temperature. It's looking at your heart rate variability. It's looking at changes in perfusion or blood flow in your skin. So it is kind of cool if you're into that type of thing. Do I think that it is a major breakthrough and doing anything that different than other ways to track your cycle? Not necessarily.
Up with.
Sorry, it just cut out. I didn't hear what you said.
I'm sorry. So can you hear me now?
Yeah.
Okay. So something went off on my phone and I couldn't hear what you were saying. You said, do I think it's a major breakthrough? And what did you follow up with on that?
Yeah, I don't think it is a major breakthrough that's doing anything that markedly different. I think it's just like a little fancy or high tech in that it's not just measuring changes in your temperature, it's also looking at other vital signs and kind of putting all the data together.
Mm-hmm.
So I think if you're into that kind of thing, it could be cool to try. I've heard it's expensive.
Yeah.
So I don't think that everyone needs to use this.
Okay. All right, next question. I am trying to conceive my first child. I'm 35 and was just told I am pre-diabetic. I also have PCOS. I'm 270 pounds, but live an active lifestyle. Is it more important to try to lose weight or begin seeking fertility help given my age?
I think both are equally important.
Yeah.
I don't think that they should be done sequentially. I think these things need to be worked on simultaneously. Your weight loss journey may help to alleviate some of the PCOS. Losing up to 5% of your body weight if you are overweight can help to restore regular ovulation, or at the very least make you more responsive to the treatments that we have at our disposal to help you get on regular ovulation schedule. So I think that they're really important too, to just optimize yourself for pregnancy.
Mm-hmm.
We know that there's a relationship between elevated BMI and central adiposity, especially, which can be a marker of cardiovascular health, and outcomes like embryo implantation or pregnancy loss. So I don't think that anyone should blame themselves if they're struggling with their weight and they've experienced infertility or miscarriages, but we know that these things are related, and there's multiple factors that go into your fertility. And so whatever you can do to optimize your overall health is going to success and set you up for a healthier pregnancy as well.
Yeah, I agree. And I also think as well, potentially getting a maternal fetal medicine specialist consult, preconception consult as well. So we can look at it from the pregnancy end and counsel you about what could be done to help improve pregnancy outcomes, given where you are now and then what your plans are. I hear all the time that people say, well, the doctor told me I need to lose this much weight before I can even try. I don't necessarily agree with that approach. I think you got to be, especially in this age group, more proactive about everything and kind of work on a plan together with the team. Because sometimes they may not ever get down to that weight. And the next thing you know, 2 more years have gone by, which could also affect your reproductive capacity, especially in that age group. So, it's not always, the answer is not always lose the weight and come back and see me later. That's not, especially when you're talking about trying to conceive. Would you agree with that?
I 100% agree with that. And I also think it's a whole different topic, but some centers have BMI cutoffs. And I think there's two different issues at play, and people don't really talk about this a lot. One is the capability of that center to safely do certain procedures, like an egg retrieval, which needs to be done under some degree of anesthesia. Some centers, especially in an outside of hospital setting, may not be certified to, cover cases where the BMI is over 40. So that's something to look into even before making your consultation, if that's a concern for you, and you think that you may need to be in a situation where you're doing IVF and having that type of a procedure. And part of it is also just consideration about making sure you're minimizing risk going into a pregnancy. But I agree, for anyone with any chronic health conditions, whether it be elevated BMI or other issues, not appropriate to say, let's wait till this problem goes away and then start trying, because fertility is such a time sensitive issue.
Agreed. Okay, next question. I'm turning 42 in March. My AMH a year ago, so 41ish, was 1.3. Do I have a chance with my own eggs? I'm planning to start IVF coming soon. And I guess their plan is to have the child carried by a surrogate. So 42, does this person have a chance to have a successful pregnancy with their own eggs?
Yeah, I mean, I think you're only going to know if you try. I would say it's good to be mentally prepared that your AMH, is one thing, and that's the one thing you can know in advance, but going through the actual cycle will be therapeutic and what you probably need to get you there. But also it's diagnostic, because we are going to get insights into how your body responds to the stimulation, and egg quality based on how the eggs fertilize, sperm quality based on how the eggs fertilize, and also egg and sperm quality based on how those fertilized eggs grow and make it to day 5, day 6, day 7. my advice, and there's a lot of different centers with different schools of thought, for your age would be to consider doing genetic testing,
Yeah. Oh, yeah.
right? Genetic testing, all testing has its flaws and isn't perfect. But I think in a population of patients where we are expecting a very high embryos that might be missing chromosomes or have extra chromosomes, that's the number one mechanism linking advancing age to difficulty getting pregnant and miscarriage. I think that it makes sense to apply that pre-implantation genetic testing, or PGT, where we remove some of the placental cells, the future placenta, from the part of the embryo before freezing them, and send them off for genetic testing to figure out if those embryos have the right number of chromosomes. If they don't, we're not going to use them. If they do, then they have a really high chance of implanting. Once you have a normal 6 chromosomes, the chance of it implanting is very high. It's not perfect.
Yeah.
It's never going to be 100%, but it's going to reduce your risk of a miscarriage, which is higher at this age. Now, there are some centers that may be a little bit shy or weary of using PGT, and the reasoning is as such. They're thinking if you're over the age of 40, yes, they know that this aneuploidy, or having the wrong number of chromosomes in an embryo, is a real problem and it's prevalent. But they also know that sometimes that can limit the ability of a fertilized egg to grow to that stage that's required to even have the ability to test. So they will hope for the best and maybe not even grow them to day 5. They'll say, whatever we have on day 3, let's just put it back, and we'll put back multiple. And that's kind of an old school way of doing IVF. I'm not saying it's wrong. There are major risks associated with it, like having twins, which are high risk pregnancies, and miscarriage, right? So as a first stab at IVF, I would recommend doing the genetic testing. I'm not a doctor that never does fresh transfers, that never transfers an embryo without testing it. I do that, but that's never my plan A.
Yeah. Gotcha. Okay. Okay. Just wondering if you have, I'm sure you do, any experience with fertility issues with someone with Didelphis uterus. So the Didelphis uterus, talk about Didelphis uterus, and then just kind of go into a little bit about, it's a Mullerian anomaly, or an anomaly of the uterus. So talk about that, and then what it could potentially mean for fertility.
Yeah. So it's actually so interesting. This is one of the things that really drew me to my field. Learning about how the body develops. So the uterus, which is one cavity typically, actually arises when you're a fetus in your mother's womb from these 2 ducts, or like tubes, let's say, and they come together as the body is forming, as this human is forming, and then they fuse. And there's this wall or junction that's between that those 2 fused ducts, that eventually gets resorbed and just dissolves. And that's what leaves you with a uterus. So when you have a Didelphis uterus, what that means is you actually have 2 separate uterine cavities, and it's from a failure of fusion, right? You can also have a septum, which happens later down the line. The fusion occurred, but that wall never got dissolved. That's a septum. But this is one step before that. So having a Didelphis uterus means you don't have one single cavity attached to 2 fallopian tubes. So, you know, so basically what happens is you have a smaller space, less surface area potentially. It doesn't necessarily always mean you're going to have infertility, but there is an increased risk of miscarriage. And that's usually the main mechanism by which, patients of mine will have difficulty conceiving. It's more about the sustained implantation. And then, down the line on your end of things, there's higher rates of preterm delivery. And there can be very different configurations. You can have vagina, 1 cervix, 2 uterine cavities. You can have everything separate, so everything is duplicated. Oftentimes we pick that up with a patient who says, I'm using tampons, but I'm still like bleeding everywhere. So it's so interesting. But I typically tell my patients, it's not necessarily going to mean you're infertile, but it could be harder to hold on to a pregnancy.
Yeah, and then most of these uterine anomalies will come up or be diagnosed if they happen. I've had them diagnosed because they happen to get a CT scan for some unrelated reason, or they were having miscarriage issues, or they're pregnant in their first trimester and we pick it up, although that's not the best time to diagnose uterine anomalies because you can't really tell for sure what it is. I just had a case the other day that was initially called a bicornuate uterus, and at the 20 weeks anatomy scan, when we do our cervical length, there was 2 cervices. So she didn't know. and she ended up going to full term, 39 weeks with the Didelphis. Don't ask me. I mean, I've never seen somebody go. Usually they do deliver preterm, first baby,
Yeah.
and figured out this on the left side, and she delivered vaginally. And so, you know, it's good to know, and people find out in all kinds of different ways. As a matter of fact, she had a CT scan right before she got pregnant after a car wreck, and they told her it was a bicornuate uterus. Well, I reviewed the images, and it's very clearly a Didelphis. So, you know, it's not always easy to pick up even on CT scan. They just know there's something there, or something different about the uterus. But yeah, people find out about uterine anomalies in all kinds of different ways. I've heard everything, just about everything.
Yeah, I definitely pick these up sometimes,
Oh, yeah.
and I'm the first one to tell the patient about it
Yeah.
at the initial evaluation.
Yeah. Okay, so next question. All right. I'm 42, just in a 2-week wait of my 6th IVF round. I keep getting pregnant, but low HSG levels means it just won't stick. All the doctors I've dealt with all have no experience with my condition. It needs to be treating like a normal unexplained fertility. Do you have any suggestions? I mean, just looking at this question alone, I don't know if they're testing the embryos or not, genetics. Hopefully they are, especially after 6 rounds. So let's just say they're not testing the embryos. The first thing they should be doing is testing the embryos, correct?
Yeah. I mean, this comes back to what I was
Yeah.
just talking about with our 42-year-old friend who asked that question.
Yeah.
About odds of success with IVF. So yeah, if we're not doing testing of the embryos, now's the time to definitely implement that. And I would definitely have that conversation. If you are doing testing, then I think you need some further investigation to understand why you're having recurrent implantation problems. And I would look directly inside the uterine cavity. I would do a hysteroscopy, and I would screen for, you know, lesser known causes of recurrent implantation issues like inflammation or infection in the lining. I would look for polyps, fibroids, and I would really look at the quality of the embryos.
Yeah. Okay, next question. Make sure. Okay. So say you have someone who, for whatever reason, they know based on career plans or whatever that they're likely going to be trying to conceive for the first time after age 35. When would be the best time for them to consider freezing their eggs, if freezing the eggs is on the table for them?
I mean, I get asked this all the time. I think if you feel pretty certain that you're going to wait until 35 and older, then, and that if you wanted to have more than one child, especially, to me, it's a no-brainer. I think that you should at the very least have a consultation and have a conversation about it, thinking about it and asking this question, and you're also thinking it's very likely you're going to wait till 35 and older, my advice would be to just do it.
Yeah. I agree. I mean, I think if you're already thinking about it, then it's just get the consultation, like you said.
Right.
The other thing to consider is with your age, you know, the longer you wait, and people don't always understand and get this, you know, I had someone tell me, oh, if I don't deliver by the time I'm 38, I'll just freeze my eggs. Well, you can freeze your eggs at 38, but you're not going to get more than likely what you would have gotten at 32 or 31 or 33.
Right.
So we can't, just like I say, IVF is not always a valid plan B for everybody because it didn't work for everybody. It didn't work for me. Just waiting until whenever to freeze your eggs is not always going to get you what you want either. So if you're starting to think about it, it's better to talk to someone like Dr. Sekhon to come up with a plan about when the best time would freeze, because, you know, you want to get the highest yield. I know one of my friends freezed her eggs at age 40 and got 4 eggs. And she was advised to do another one, and I'm not doing another one. And you know, it's going to happen. You're not going to get it, likely not get as many eggs, right? So that does play a role.
Right. Yeah. So I have 3 important key messages about egg freezing. And I'm doing a free seminar tomorrow that is on Zoom with RMA of New York. If anyone wants to tune in, it's going to be all about egg and embryo freezing. And these are the types of things we're going to talk about. But the 3 key messages are: your uterus doesn't age. So I think while egg freezing, like any other technology or treatment, isn't perfect, it's a really great way to get around reproductive aging because your uterus doesn't age. You always have the ability to have an egg that was frozen be turned into an embryo, or have an embryo that was frozen and have it implant. Even if you're at a place where you don't make your own hormones because you've gone into menopause or you had your ovaries removed. So that is a really fascinating fact that a lot of people don't know. Secondly, the two most important things that will dictate your chance of success if you're coming back to use your frozen eggs are the age you were when you froze your eggs and the number of mature eggs frozen. Time and time again, when I do a lot of clinical research, the two factors that always stick out when you control for all of the other things at play. And then the third thing is the younger you are, the less eggs you need to feel confident. The older you are when you freeze, the more eggs you need to feel confident about your chances. And that's kind of part of number two. But those are the three key takeaways that I think everyone needs to know if they're thinking about freezing their eggs, because for the same amount of effort, money, and time, you're going to get a lot more out of it just because of being at a younger age.
Yeah. Those are three great points. And I am absolutely on board with that. You know, I'm a huge proponent for egg freezing, and talk to anybody I can about it who will listen to me, especially those that are in careers like, you know, not just medicine, but similar, where you anticipate delaying childbearing, you know, for whatever reason, you know, you're on a long path. Just go ahead and talk to somebody about it once, twice, maybe three times before you even decide, but just so you can kind of evolve over time what your plan is going to be, especially as you start hitting that 30, 31, 32-year-old, you know, mark. That would be my, you know, my piece of advice. Okay. Best time to freeze eggs, and best time if considering, oh, no, that was it. Sorry. Egg versus embryo freezing. Both of us are 33, not ready to try yet, and will most likely be 35 plus when we want to try. Pros and cons.
Yes. So egg and embryo freezing are currently the two mainstream ways to preserve your fertility, right? That's really the only options that you currently have. Experimental things are out there like freezing ovarian tissue, but those are not ready for prime time yet. And when you think about those two options, oftentimes people just focus on what's happening in their personal life, but I think it goes beyond that, right? Obviously, if you're single and you want to preserve your fertility, the best option is egg freezing. But if you're in a relationship, you also need to consider both options, right? When you freeze embryos, you've combined an egg and a sperm together in a way that is irreversible. And so technically, both people involved, if you're not using an anonymous donor who has relinquished their rights, their parental rights, you know, that's a joint venture, and your method of fertility preservation is only as good as your ability to come back and use what you froze, right? So if God forbid you break up or something happens, that is probably not going to be an option. Even if there was some sort of prior agreement, it can always be contested. And so the reason why egg freezing is beneficial is that it gives you ultimate flexibility, and it's simple. It only involves you. And if you want to reserve your ability to have children, biological children with a future partner, then that's the best approach. The medical benefits all tend to be on the side of embryo freezing, right? So when you go to thaw out eggs, not every egg will survive the thaw, fertilize successfully, grow into an embryo a week later. And not every one of those embryos is going to be genetically normal, even if you're 20 or in your 30s, right? No one is capable of making 0% abnormal embryos. That doesn't exist. So when you freeze eggs, you're freezing potential, but you don't know what lies ahead. The younger you are, the less worried you are, because there tends to be less attrition. And at the end of the day, a large majority of whatever turns into an embryo is going to be healthy and normal, right? And if you have a decent number to overcome those odds, then it's not a big deal. And these are things that your REI that's helping you through this process should be talking to you very honest and straightforward about their statistics at their clinic and what they could expect. Now, when you freeze embryos, you've already gotten past all of that. Additionally, you have the option to genetically test those embryos. So you really know what you're freezing. And the only question mark is, will the embryo survive the thaw and will it implant? So you're much closer to the end goal of a live-born baby. Now, embryos tend to thaw out invariably well. High thaw survival rates. The rates that I quote at our clinic are in the high 90s, right? Like 98% of the time. Very rare to have an embryo not survive the thaw. Eggs, we expect some eggs to not survive the thaw. Our averages could be around like 85%. The younger you are, the higher it is. Maybe it's like 90 to 95%. But there's more variability there. So, you know what you have because you've gotten past the attrition and you can genetically test. Those are the two major advantages of embryo freezing. But otherwise, flexibility is the major advantage of egg freezing, and only you know your relationship and what makes you comfortable. And I've had some couples where they've done a round of eggs and they've done a round of embryos, right? So I think there's so many different ways that it can look, and it's important to be aware of those issues.
Yeah, great summary. And just think about there's a celebrity couple that happened to where they froze embryos and then split up, and
Sofia Vergara.
Yeah, huge issue. So that I'm not trying to poo-poo anybody's relationship. I'm not, but you got to be realistic when making that decision about freezing embryos for the future. So yeah, and then Dr. Sekhon can be the mediator and kind of give you some advice on what's best for you as an individual and as a couple. Okay.
Yes.
We got to talk about this. Egg quality. Egg quality can be improved according to social media and the internet by various concoctions, recipes, supplements to take this to improve your egg quality. And, you need to take this diet or that diet. Is there anything that we know of that can change your egg quality?
No. Time.
Yeah, I mean, again, we mentioned earlier that it's kind of predatory, and I as someone who was affected by egg quality based on my age, I take that kind of personally because I was extremely healthy. I was, I worked out all the time. There was very little I could have done, and then I hear people being told they need to take this supplement, buy my supplement, buy this fertility thing, and you're going to increase your egg quality, improve your egg quality. Drink. And there's literally someone promoting a recipe of this soup to improve egg quality, and it just drives me bonkers when I see those things. I think it's again not fair, and I know people that are in that boat will try just about anything, but yeah, we had that on our list, right?
Yeah.
It's not fair, and our bodies do what they do. As Dr. Sekhon said, the uterus is not subject to time like the eggs are. That's just what it is. But there was a question about PRP, what is it? Platelet-rich plasma.
Platelet-rich plasma.
Mm-hmm. This is a new fad. They were asking, does it work? Dr. Sekhon, did you hear me?
Yeah. You just cut out for a second.
Sorry. Does the platelet-rich, is it platelet-rich plasma?
PRP, yeah. Platelet-rich plasma.
Does that help to improve egg quality?
So there's no data to suggest that, but I just want to explain what it is, because I'm sure if you do a quick Google search about egg quality, this is going to be something that's trending. And, I want to say that sometimes I think I come off as someone who poo-poos anything new and sexy that's out there. I love my field, and I think that it has tons of rapid advancements, and I am not reluctant to, take on any new advancements that have data to back it up. But and I think that this could be an interesting area for future research. There are active trials and studies that are forthcoming, but right now this is not ready for prime time, in my professional opinion. It's not backed by any reputable women's health organizations or health societies, and it doesn't have any randomized controlled trials. So PRP is basically also known as ovarian rejuvenation. And it's basically touted as a solution for ovarian aging. We have a set number of follicles. They deplete over time. So both quantity and quality change in irreversible ways. That's their traditional dogma that it challenges. And basically, it's being used in other fields as a form of regenerative medicine. So that's where the idea and interest came from. And basically, it involves taking whole blood, centrifuging it, and taking this platelet-rich plasma portion that results from, the separation of the different components of the blood. And we know that platelets actually are armed with tons of different growth factors. It's part of the recovery process in any sort of injury. Yeah. And so what's done is this plasma that contains like 7 times the normal concentration of platelets in your whole blood is then injected into the cortex of the ovary. So this does involve having a surgery, which could be like a egg retrieval procedure done vaginally, because you can access the ovaries that way. And they inject this into the cortex of the ovary. So it's a really interesting idea. And I think that we just need to learn more about it. There really haven't been any
Mm-hmm.
unbiased, proper clinical trials, a randomized controlled trial. And also, we don't really know enough about the safety of it either. And if
Yeah.
it involves some sort of invasive procedure to do it, and it's very expensive,
Mm-hmm.
I think it's important for women to know that this is purely a level of increase.
Mm-hmm.
While the p-value says it's significant, is it clinically meaningful? And have there been any studies to show improved pregnancy rates? No.
Mm-hmm.
So, just keep your ear to the streets on this one. And trust me, if this ends up being something, I'll be the first to be shouting it from the rooftops.
Yeah, yeah. Yeah, so that's just another thing to watch out for. I this whole thing about targeting we mentioned earlier, both pregnant and trying to conceive individuals with these types of things, especially when they're vulnerable and willing to try anything. Um, I personally, as you know, my accounts, I have a lot to say about that, and I know you feel the same way. We just have to. What people have to understand is that, and I say this all the time. You could find a paper to support just about anything. You can. This trial showed this. However, there's something called the General Medical Consensus, where the American Society of Reproductive Medicine, ACOG, SMFM, are responsible and tasked with looking at the totality of the evidence before making recommendations, especially in the fields of fertility, pregnancy, high risk pregnancy. Because if we looked at and changed our practice based on every article that came out, we would have no standards of care. Everybody would be getting something different. We'd be running around like chickens with our heads cut off because trying to chase down each paper. So you cannot change your medical practice or recommend things to patients based on one or even two articles. It takes much more than that. And I think that's what the general public doesn't understand. I could Google anything and probably find something to support it. But that doesn't mean it's going to change what I do for my patients. You have to look at everything that's been published, synthesize it, bring it all together to see if a recommendation can be made. And that's the same in your field, right?
Correct. Yes.
Yeah.
And a lot of these things are still experimental,
Yeah.
but it's scary because you see it being applied as if it's prime time.
Yeah.
And patients come to me and ask about it all the time. And so I always feel like I'm the naysayer poo-pooing all of these things,
Yeah.
but I use evidence to guide everything that I do. And I think you couldn't have said it any better. Yes, you can find a study to prove any one thing or one statement,
Yeah.
but it's really about the body of evidence that exists.
And that's why I hear all people probably, well, ACOG is this and then, but they have an ASRM, the three main ones, ASRM, ACOG, and SMFM, have very crucial roles to the practice of obstetrical, trying to conceive, fertility, all that care, because that's what they're like I said, tasked with, is looking at all the evidence and making recommendations. If we didn't have them, it's going to be the wild, wild west out there. So they're needed, and they have a vital role in standards of care, and we need to respect that, because there has to be some regulation and some oversight as to what we're doing and why. So,
and I sat on a task force, and it took 2 years to put together a task force document for the ASRM, and it was a huge team, and it was an exhaustive effort.
Well, I mean, but that's the right way to do it. Sometimes it doesn't take 2 years, but what you are supposed to do is put people together in a room with differing views, with differing takes on that, to come to a consensus. And sometimes that takes time, but that's the right way to do it. And that's the best way to do it for patient care. Okay, last question. And this is going to be a loaded one. MTHFR gene mutations. Anybody that watches this knows my stance on this, and I get it all the time. Well, that's your opinion. No, it's not my opinion. When I share what SMFM, ACOG, and others, American College of Medical Genetics, say, those are all medical organizations that looked at the totality of the evidence, and I am educating people on my platform about that. It's not my opinion. And the general recommendation is, and the consensus is to not test women or egg-producing individuals for MTHFR gene mutations. They do not cause thrombophilia. They do not cause pregnancy loss. It does not diminish your ability to synthesize folic acid and utilize folic acid. But the reality is there are a lot of accounts and a lot of companies and a lot of individuals who use MTHFR gene mutation it's not mutation. We shouldn't be using that. It's a gene variant. Just like as Dr. Jen Gunter says, just like eye color, hair color, it's a variant, to guide clinical care and to treat people differently and tell them this is what caused it when they're missing what likely did cause things. So what I wanted to ask you about is, and it happens on social media with other reproductive endocrinology and infertility specialists who talk about MTHFR causing recurrent pregnancy loss, that they need to take methylfolate instead of folic acid while trying to conceive. You know how I feel, and you don't have to agree with me, how I feel about that.
I think I agree.
But what say you? What say you?
So I think it's important to just go back to the basics for anyone that hasn't been following the MTHFR drama that has unfolded over social media and the internet. But it is this antiquated idea that either is being perpetuated by people that haven't kept up to date with the literature and the recommendations, or those that are trying to profit off of the greatest scam. And I say it's one of the greatest scams because MTHFR is an enzyme, right? And it basically converts methylene tetrahydrofolate into 5-methylene tetrahydrofolate. And it's important for the process of breaking down folate and metabolizing it, which we know is important pre-conception for the prevention of neural tube defects. It also converts an amino acid homocysteine to methionine, and elevated homocysteine levels have been associated with disease across the board, including cardiovascular disease and adverse pregnancy outcomes, infertility, and recurrent pregnancy loss. So it is a great scam because there is a high prevalence of variants, right? 20 to 40% of the population might have one of these variants that can come up positive in testing, saying that you have a mutation. But these variants are deemed benign based on what we now know. But previous to this, people were saying, okay, if you have one mutated copy and one functional copy, that it could be significant. If you have two mutated copies, then that definitely is significant. And you're at an increased risk of having these adverse outcomes. So the solution is give you that 5-methylene tetrahydrofolate directly, because your body is not going to be able to metabolize folic acid, and this is going to help solve your problems. And this is not true, and it's problematic because the whole reason we tell women to take folic acid is to prevent neural tube defects like spina bifida, important 3 months preconception, and the data is not there to suggest that this is just as effective at doing that. And that's the whole purpose of why you should be on it, needle vitamins. So it is a huge scam because anytime something affects 20 to 40% of the population or more, I mean, how did we get this far? How do we exist as a human species if this is so significant? And it's actually brilliant, because if you know that sending this test off is going to yield a positive result, a mutation in so many different people, then you can also, peddle supplements and approaches to deal with it. It's a fake problem with fake solutions. So that's how I feel.
Yeah. Well, thank you. And, you and I haven't personally talked about this. I mean, we've talked I think we did a post recently about folic acid, but, it's something that needs to be said. And I know people, because they've been told by their physicians, and I understand the physician-patient relationship is very important. I'm not here to step on anybody's physician-patient relationship. I'm here to educate. And this is not an opinion. This is supported by multiple medical organizations. It is, if you trace it back to anybody that's recommending MTHFR gene variant testing or methylfolate instead of 5-MTHF instead of folic acid, it all links back to selling something and making a profit, especially on social media. And that is the bottom line. That's why it's there. Like it or not, that's the truth. And and as much hate, I'll probably get more hate about this issue than anything else that I ever talk about. But I'm not going to stop, because I also feel like it's targeting, and it's also predatory behavior on people who do promote testing for MTHFR gene variants. And the other thing, as far as saying it causes your pregnancy loss. And the truth of the matter is that most people after recurrent pregnancy loss will end up going on to conceive. Barring any other major medical issues, that's the reality. And it wasn't because they tested for MTHFR gene variant and put you on baby aspirin or did whatever. And, we just got to get that message out there, right? It's not a cure-all. It's not a magic diagnosis. As Dr. Sekhon said, with as many people as the gene variants affect, we would have a lot more sicker people walking around this earth than we do. So it just doesn't make any sense
Right.
biologically that it's going to have that effect. So I'm glad we're on
I'm
the
so
same
glad you
page.
said that last part. The
Yeah.
chance of a subsequent live birth is very high in
Yeah.
anyone with recurrent pregnancy loss, like you said. So I get a lot of patients who are very emotionally charged about this topic because they insist that it's the baby aspirin that got them to where they are now, and they have their baby, and how could I be going against what their doctor previously had told them in a prior pregnancy? So I think it's important to realize that if you keep trying, eventually it will likely work out. And it probably has nothing to do with that element of it. And I
Yeah.
think so it's an emotionally charged topic because of that. And also because what you're saying is hitting a lot of people hard in their wallets who are peddling
Yeah,
these supplements.
it is. And that's one thing I cannot, yeah, I know you feel the same way. It literally infuriates me when I see that and it links back to a link in the bio where they're selling crap. And that's essentially all that it is.
Mm-hmm.
And,
Yeah.
we have to do better. That's one of my new hashtags, actually, do better about, not only this topic about it, but other things when it comes to some of the voodoo that's being peddled out there. So thank you so much.
Yeah.
This was great, as usual. We're not going to get time to go through all the questions that were here. We'll just have to keep doing these and get questions answered. So I hope this got great topics covered, and I hope this helped get some people some information. How can they find you on Instagram? And you also have a blog.
Yes. So my handle's at Lucky, my first name, Sekhon, Sekhon. So you can follow me. I'm actually doing a Q&A on my personal Instagram today. And also I have that free virtual event for anyone, anywhere in the world or the country that wants to tune in on egg freezing tomorrow. There's a link in my bio where you can sign up for that free event. And I also do have my own blog, www.theluckyegg.com. And if you have any ideas of things that you'd like to learn more about, that you want me to write about, please feel free to DM me.
Yeah, or you can put it under the comments here, because I know Dr. Sekhon goes back and looks at the comments under the videos. But after this, text me those three things so that I can advertise that in my stories for you. The Zoom, the
also
Q&A
last
today.
but not least, I was just gonna say I practice as a clinician at RMA of New York. So